I think you will understand it wouldn't be fair from my part on to say some words in the memory of Professor Bronnemark and his good friend and colleague, Richard Scalak, if we are going to talk about immediate loading procedures, because these two scientists were the fathers of the Bronnemark novum. And Bronnemark novum was the very first immediate loading protocol with which it was possible to provide our patients with a definitive procedure, with a definitive solution, the same day that the surgery has taken place. In other words, I think Bronnemark novum was the predecessor of this trefoil that we are presenting here this afternoon. Edentulous patients were always a big concern for Professor Bronnemark. He very often said that nobody should die with a set of teeth in a glass of water by the bedside. And he also very appropriately named the low edentulous patients oral invalids or oral amputees. As we all know, edentulous patients are frequently affected by functional and also psychological problems that tend to multiply as the progressive and irreversible resorption process of the arch continues. The decline of neuromuscular control as a result from old age, combined with this resorption that I was mentioning some seconds ago, converts the removable complete prosthesis, but very especially the lower jaw one, in unstable devices that are really very difficult to bear. Being aware that an overdenture on a couple of implants was not a satisfactory solution, and that fixed bridges on 6, 5, or 4 implants with its components, abutments, screws, frameworks, ceramics, were too costly for the majority of the patients, Professor Bronnemark and Richard Scalak developed during the 90s what they called the same-day teeth in order to find an affordable solution for those edentulous lower jaw patients. With this procedure, where they used 3 one-piece implants and some set of guides so that they could place the implants in a predetermined position, and after the surgery, the prefabricated components could pass passively on them, they could finish the work, the fixed definitive prosthesis the same day that the surgery has taken place. With this procedure, we treated 70 patients in the late 90s and until 2004. And in our last follow-up, our 13 to 17 years follow-up this year, we still have in function 62 of the 70 bridges. It's not marvelous, but I think it's quite an acceptable result. Anyway, it has been very gratifying for us to treat patients from all over our 7 islands archipelago and also from other parts of Spain in only one day. But having said that, Bronnemark novum has its limitations. It's not so easy to achieve this passive fit that we want to have for this kind of procedures. And post-surgical prosthetic complications were too frequent and very often not easy to solve. So it was clear that a new design, as well as the utilization of technology and components that are available today, was needed. And that's exactly what Dr. Iguchi and collaborators have done with this trefoil procedure that we are presenting here today. The trefoil structure has 3 internal compensation mechanisms so that the framework has the capability to correct vertical, horizontal, and also angular misalignments, so it's very easy to achieve a passive fit on the implants placed. Also, the trefoil implant is a new implant where we have, of course, it's a one-piece implant with a threaded part that is a tionite surface, and a transmucosal or abutment part that is machined titanium with a conical internal connection that has also the advantage that is compatible with our components from Nobel. The indications for the trefoil procedure are edentulous lower jaw, or soon to be edentulous lower jaws, where we have at least 40 millimeters of mouth opening so that we can have space for our drills and our templates. We need at least a width of 7 millimeters from the platform that, as we're going to see later, we have to prepare to place our templates and our 5 millimeter diameter implants, and also a vertical height of at least 12 millimeters, because the smallest one of the trefoil implants is 11.5 millimeters long. It is a very magnificent solution for class 1 skeletic relationships. It's also a good procedure for class 3 if they are not too severe, and it's not indicated in class 2 because in those cases the framework would invade the space of the tank, and that wouldn't be a comfortable situation for our patients. As we have said before, we have at least a need of 12 millimeters height, so it's contraindicated if we have extreme resorptions, bones type E, where we don't have at least these 12 millimeters, and situations where the health of the patients don't make them capable to resist a minor surgery procedure. So when it comes to the surgery, after studying the case, the first thing we're going to do is release a flap from second molar to second molar so that we can prepare this bone platform that we need. We make some lateral releases at that level, and after that we can prepare comfortable this bone platform. We explore, of course, the concavities, possible concavities on the lingual side so that we won't make any fenestration with our drills or implants. Also explore the mental foramens and the possible loop, anterior loop, that the nerve very often has. And then we proceed to use this first guide. That's the guide template. With this one, we are going to mark the sites where we're going to place our implants. And with these guide pins, we make also an idea if we are in a correct situation, taking into consideration the upper jaw. The second template is this evaluation template. Here we go with the 2 millimeter twist drill to full depth. And we make clear also that we are well seated on the platform. The third template is this one, the positioning template. We fix it with 2 guide pins in the distal sides, and is the one that we're going to use to prepare the osteotomy of the central implant. Here we see how we are using a template for drills and progressively diameter templates and drills until we have the osteotomy totally prepared. Then we have this implant template that we are going to use to place the implant. It's a 5 millimeter diameter one, and we're going to use the same template also if we have to use the screw tab. And that's the last of the templates. That's the V template. We use a temporary screw in the central implant to fix it, and then we prepare some small osteotomies with a 2 millimeter twist drill so that we can place a couple of stabilizing provisional screws, and so that the distal implants can be placed in an absolutely fixed manner without any movement of the template during the preparation of the distal sides. We use the same template, drill template, but now in a horizontal manner, and we prepare both sides at the same time. Here we see we are placing the distal one fixture, and immediately after the left one. As soon as the implants are placed, we can wash properly, because normally we have a lot of bone chips after preparing the platform and the implant sites. We control that we have at least 35 Newton centimeters of primary stability, because if we don't get it at least in 2 implants, it's better not to do immediate loading. And we check that the framework has a very passive fit on the 3 implants, as we can see here. After that, we can close, and immediately after suturing, we can proceed, as we can see, as we're going to see in a second, the verification index that we have now on the implants. We can send that to the lab. The technician can now fabricate his master model, his work model, and in this work model, he's going to place the framework, and is going to fix the mobile components to the framework with pattern resin, with Duralay, or with laser welding. And there are many ways to perform the definitive prosthesis. We like very much to prepare a complete prosthesis before we prepare also the place for the framework, so that we can take an impression of the framework in the mouth, utilizing this removable prosthesis as an individual tray. Here we have the framework with a piece of rubber dam. We make a control that everything fits okay, that we don't have any undesirable contact, and that the occlusion is okay. We take this impression with polyether material, with impregum, and we can take also the bite registration. With all that information, the technician can finish the work. He has placed some opaque on the framework, and here is the fixed bridge finished. We take some healing abutment that we have placed on the implants during the time that the technician was working, and we are in the moment that we can place the definitive fixed bridge only hours after the surgery has taken place. Here we see the X-ray of the same patients after the surgery. I think we can say that with the Trefoil we have an affordable solution, because we only need few components, 3 one-piece implants, the framework, and 3 screws to fix the definitive prosthesis. I think we can say also that this biologically well-accepted procedure, because we make a rigid splinting of the 3 implants from the very first moment, and the use of one-piece implant has demonstrated us during the years that is very well accepted by the bone. As you can see here, in a predecessor of the Trefoil implant, that's a novum implant, but 17 years after placement, you can see that the bone is much higher than the first thread. And that's something that happens when we don't have gaps, when we don't have micro movements. And last but not least, the timeline of the Trefoil is something also very encouraging, because we can begin our surgery at 8 o'clock in the morning. 1.5 hours later, we can send to the technician the information he needs, and approximately in 6 hours, depends on the technicians, from 8 o'clock to 3 o'clock, we can have the definitive fixed bridge in the mouth. To conclude, I think with Trefoil, we have an affordable one-day definitive solution, not a provisional one, for those patients who, in my opinion, benefit the most from the osseointegrated treatments. And those are, without doubt, the lower jaw edentulous patients. Thank you very much.